In Chapter 13, we'll discuss the analysis of vaginal secretions. The most common gynecologic complaints are vaginal discharge, vaginal discomfort, and vaginal odor. Three major causes of the above symptoms include bacterial vaginosis, candidiasis, and trichomoniasis. The clinical presentations of these three causes are similar, but treatments are different based on the causative organism. So there is a need to differentiate this by the analyzing of vaginal secretions. It's important to differentiate the causes, and this is done by direct microscopy tests. Wet mount examination, the amine or whiff test, the potassium hydroxide examination, and gram stain. As always, specimen collection and handling are crucial for accurate laboratory results. The healthcare provider must use appropriate collection techniques to maximize the recovery and detection of microorganisms and other cellular elements. The healthcare provider collects vaginal secretions during a pelvic examination. They are told not to use speculum lubricants as these may contain antimicrobial agents. So if we're looking at bacteria as the causative agent, these will be dead and will not grow in culture. A Dacron swab on a plastic shaft or a sterile wire loop is used to obtain the vaginal secretions. The collection device used is important. Cotton is toxic to Neisseria gonorrhea. Wooden shafts are toxic to Chlamydia trachomatis. It's best to use more than one type of collection device. After collection, the labeled sample is transported to the lab ASAP. In addition to routine labeling, appropriate medical history is very helpful in knowing what the doctor is looking for during the exam. The testing is performed as soon as possible. The sample is stored at room temperature. Do not refrigerate, as this will negatively affect the recovery of Neisseria gonorrhea and detection of the trophozoite Trichomonas vaginalis, which is identified by movement. So if it's dead, it's difficult sometimes to see that they're there. If cultured organisms are suspected, C. trachomatis or viruses, refrigeration is preferred to prevent overgrowth of normal flora. So again, we need to know what the doctor is looking for so that we can handle the sample properly. The swab is placed in normal saline, or roll the swab on a slide and add a drop of saline to observe microscopically. The pH of vaginal secretions is very important, and this is determined using commercial pH paper before placing in saline or perform other testing. pH determination is valuable in the differential diagnosis of vaginitis. The normal pH range is 3.8 to 4.5. A pH greater than 4.5 is associated with bacterial vaginosis, trichomoniasis, atrophic vaginitis. The predominant normal vaginal bacteria or normal flora are lactobacilli, which produce lactic acid and hydrogen peroxide to maintain the normal acidic pH in the vagina. The bactericidal properties of hydrogen peroxide prevents overgrowth of some microbes such as Gardnerella vaginalis. So this can be found as normal flora but in very small numbers. The absence of lactobacilli is associated with bacterial vaginosis. Please review the video that I posted on the microscopic examination of vaginal secretions. It has a wealth of information, a lot of action, video pictures of microscopic structures and microbes. The microscopic examination should be performed as soon as possible, especially important for the observation of motile Trichomonas vaginalis, because these will die and will be difficult to identify. The swab is added to 1 ml of saline and vigorously swirled to release the secretions into the saline. Then the swab is removed. 2 or more microscope slides are usually prepared. One for the wet mount, the second for the 10% KOH preparation and the amine whiff test, and a third slide may be prepared for a gram stain if the physician suspects a bacterial cause for this condition. Begin the microscopic review of the slide by examining the saline preparation. The examination should begin with the sample without KOH using the 10x objective, noting cellular distribution and obvious cellular and fungal elements. The 40x objective is used to identify the presence of white and red cells, the quantity and type of bacteria present, clue cells, motile trichomonas, yeast, and fungal hyphae. Next, review the sample with KOH added, and this will remove or cause the rupture of white cells and red cells and make the yeast and other structures somewhat reflective and more visible. So what elements are reported when they're seen in wet mounts? Red cells, white cells, the predominant bacterial morphotypes, for example, rods or cocci, whether yeast, hyphae, and pseudohyphae are present, trichomonads, clue cells, parabasal cells, basal cells, and squamous epithelial cells. White blood cells are normally present in vaginal secretions and range in number from a few observed in the entire slide to several within every field, because they're on the lookout for invading microorganisms. The number of WBCs will vary according to the menstrual cycle, with higher levels during ovulation and menses. Red blood cells are not usually present unless during menses. It's important to have a current patient history to accompany the specimen, because if she is not in her menstrual cycle, then red cells could be a bad sign. Normal vaginal bacterial flora. The vagina has a complex vaginal bacterial flora. Large rods of lactobacilli account for 50 to 90% of microbes of healthy vaginas. These are expected to be present. They produce lactic acid, which results in a normal acidic pH for a healthy vagina, which prevents proliferation of bacteria such as Gardnerella vaginalis and Prevotella bivia. Any decrease of lactobacilli relative to the amount of squamous epithelials is an indication of an imbalance in the microbial flora. Increased numbers or a preponderance of other bacterial morphotypes are abnormal. This picture illustrates the lactobacilli, which appear as rod-like structures around the epithelial cells. An occasional yeast can be found in normal vaginal secretions, and you have to be careful when looking at the sample microscopically because yeast are visually very similar to red blood cells. Adding KOH is useful as it ruptures the red cells and leaves the yeast intact. Increased numbers of yeast or the presence of hyphae or pseudohyphae is considered abnormal and indicates candidiasis. This picture is from your textbook, and the picture on the top has yeast. They're the little round blobs, and you can even see some budding of the yeast in that picture. Pseudohyphae is once the yeast really get going and start growing, they create this structure that looks like a hyphae, and hyphae are found in fungi, and yeast are not fungi, but that's why they call it pseudohyphae, because you will see hyphae in fungal infections, but when you see something like this with a yeast, it's called pseudohyphae because it's not a true hyphae. The vagina is lined with stratified squamous epithelium, and they're often present on the swabs of vaginal mucosa. These cells predominate in wet mounts of healthy vaginas, and they're easily identified by their large, thin, flat, and flagstone-shaped appearance. They have a small centrally located nucleus and a large amount of cytoplasm that becomes finely granulated as the cells age. This photograph illustrates several squamous epithelial cells from a healthy vagina. Keratohyalin granulation is most pronounced in the centrally located cells, and numerous large rods characteristic of Lactobacillus species are also present surrounding the epithelial cells. Clue cells are formed when numerous bacteria adhere to the membranes of the epithelial cells. They need to be distinguished from aging squamous epithelial cells that are normally seen. It's a diagnostic indicator of bacterial vaginosis. They have shaggy appearing edges, the nuclei may not be visible, and the bacteria should cover at least 75% of the cell surface. The bacterial organisms must extend beyond the cell's cytoplasmic borders. So this picture, also found in your book, shows 2 clue cells and several normal squamous epithelial cells in the wet mount of a vaginal secretion specimen. So again, the cells are covered in bacteria. Notice how they extend beyond the membrane of the cell. Parabasal cells are 15 to 40 micrometers in size. None or very few are present in normal vaginal samples. You may see increased numbers in menses or postmenopausal period. Increased numbers are seen in atrophic vaginitis and desquamative inflammatory vaginitis. They are oval to round with a small nucleus to cytoplasm ratio of 1:1 or 1:2. In the first picture on the left, there's a single parabasal cell surrounded by numerous squamous epithelial cells. And on the right, I found a picture that used some kind of stain, but there are arrows at the parabasal cells. Again, they're very small, and the cytoplasm to nucleus ratio is a distinguishing characteristic. In the vagina, basal cells give rise to all epithelium that will be present in a vaginal smear. They're very small, 10 to 16 micrometers, similar in size to white cells. They are rarely observed, and I couldn't even find a picture of one. And their presence in a wet mount is abnormal. The nucleus to cytoplasm is 1:2. They're usually accompanied by numerous white cells, and they're seen in desquamative inflammatory vaginitis. Trichomonas vaginalis is a free-living organism that causes parasitic vaginitis. It is a sexually transmitted infection. It causes inflammation of the vaginal epithelium. And in females, when she's symptomatic, there will be a yellow-green frothy discharge, or she may be asymptomatic. Males are usually asymptomatic, but if an examination is done of their urine, the parasite will be seen. The T. vaginalis is pear or turnip-shaped unicellular body. It averages about 15 millimeters long, although it can vary from 5 to 30 millimeters. The optimal growth at pH is 6.0. They are identified by a jerky movement due to 4 anterior flagella and an undulating membrane. The non-motile or dead trichomonids resemble white blood cells, and stains are toxic to the trichomonads. And they're really cute. And I've seen these many, many times. And in my microscopic examination, it's like they go to this little piece of debris and they then move over to this little piece of debris. And it's a jerky movement. And a lot of times you can actually see the flagella. I've listed a little video for you to watch that shows many different microscopic videos of Trichomonas vaginalis. So on the left you see a line drawing that shows you the 4 anterior flagella and then the undulating membrane and then the size of the body, and then it has a posterior flagellum. If you look at the picture on the right, it's pointing out the barely discernible flagella, and then in the middle of the Trichomonas is the undulating membrane. Again, it's very difficult to see, and that's why it's important that these be living, because they have very characteristic appearance and movement. The amine or WIP test is done by adding 1 drop of 10% potassium hydroxide and 1 drop of vaginal suspension and mixing them together on a slide. The fumes from the slide are smelled to detect the presence of a fishy odor. And once you do one of these and they're positive, you'll say, oh, Yeah, I know what that means now. The odor is due to trimethylamine, which is released from polyamines when the pH changes due to the addition of the potassium hydroxide. In bacterial vaginosis, the altered flora produce polyamines. A fishy or amine odor is characteristic of the presence of Trichomonas vaginalis and Gardnerella vaginalis. Microscopic exam, 1 drop of 10% potassium hydroxide is added to 1 drop of the vaginal suspension. It mixes it together. As stated before in this presentation, the KOH will destroy any white cells and red cells, and that will make the yeast more reflective and more visible. Candidiasis is the second most common cause of vaginitis. Candida albicans is responsible for the majority of cases. It's part of the normal flora, but overgrowth occurs with changes in pH or normal flora. C. albicans is responsible for 80 to 92% of the cases of vulvovaginal candidiasis. There are other conditions that may predispose an individual to an infection, and these include pregnancy, uncontrolled diabetes mellitus, immunosuppression, and HIV infection. The symptoms of candidiasis are vulvovaginal itching, soreness, external dysuria, and a white curd-like discharge. When examining a wet mount microscopically with KOH, will reveal budding yeast and or pseudohyphae and increased WBCs. The pH is normal and the amine test is negative, and this is often caused by the use of broad-spectrum antibiotics or oral contraceptives. Antibiotics will kill off the normal flora, which will allow overgrowth of the candida. Oral contraceptives can also interact with the normal flora and cause this to be overgrown. One thing about taking antibiotics is they usually put a warning on the bottle that if you are on oral contraceptives, they may not work. So you need to use an alternative method of birth control. Trichomoniasis is the most common parasitic gynecologic infection. It's usually sexually transmitted, and unfortunately recurrence is common after treatment because the woman's sexual partner needs to be treated as well. Unfortunately, if you do have trichomoniasis, the transmission of HIV is facilitated. In pregnant women, it is a risk factor for premature labor or rupture of the membranes. 50% of women with trichomoniasis are asymptomatic. Others will have a frothy, bad-smelling yellow to green discharge, which gets them to the doctor right away. There's soreness of the vulva, external dysuria, which is pain as the urine passes over the inflamed vaginal labia, which is suggestive of a vaginal infection or inflammation. Dyspareunia is the term for recurring pain in the genital area or within the pelvis during sexual intercourse. There's punctate hemorrhages on the exocervix. The pH is elevated, 5 to 6. Numerous WBCs present. Often the whip test is positive. If the wet mount is negative, a culture or a DNA probe can be used to diagnose. But these parasites are difficult to culture, so the DNA probe is the way to go. Atopic vaginitis occurs in peri- and postmenopausal women. As you get older, thinning of the vaginal epithelium occurs, and there's a decrease in glycogen production, which results in dryness, soreness, and spotting, which means minor bleeds. This results in a decrease in lactobacilli and an overgrowth of other bacteria. The pH is greater than 5. The wet mount has numerous WBCs and small numbers of RBCs, and the treatment involves replacement of the estrogen. So this slide illustrates the normal findings in vaginal secretions. So the mucus is clear. It may turn slightly white or pale yellow when exposed to the air. The healthy vagina will have lactobacillus species present. The pH is less than 4.5, and the volume varies through the menstrual cycle. And on the right-hand side, there's a picture of a normal wet prep with different types of cells and artifacts identified. I want you to memorize this so when you're given a case study like question with results that you'll be able to determine which of the conditions is present. We're going to have a brief discussion on pregnancy-associated testing. Fibronectin is a complex and multifunctional glycoprotein found on cell surfaces throughout the body, as well as in plasma and amniotic fluid. It's involved in numerous important functions, and in pregnant women there's a unique isoform of fibronectin known as fetal fibronectin, and it's produced and can be specifically identified using FDC6 monoclonal antibodies. The fetal fibronectin test is used to test pregnant women who are between 22 and 35 weeks of pregnancy and are having symptoms of premature labor. I want you to know this. It's performed repeatedly, and if it's consistently positive, the risk of premature labor is high. If you get 2 or more consecutive negative tests, this indicates a normal risk. Cervicovaginal secretions are collected during an examination, and a sterile Dacron polyester swab is used. After collection, the healthcare provider places the swab into a tube that contains an extraction buffer. They seal the tube and send the swab in the tube to the laboratory for testing. They have to take care to avoid contamination of the swab with lubricants, disinfectants, soaps, or lotions. Because interference by semen is unknown, specimens should be collected 24 hours or more after intercourse. Rapid tests are available. Placental alpha-microglobulin 1 is a placental glycoprotein that is a good marker for premature rupture of the amnion in pregnant women. And as a lot of you know, rupture of the membranes, usually that's when your water breaks, but sometimes you can get a premature rupture, but it's not the big one. PAMG1 is present at high concentrations in amniotic fluid and in low concentrations in the blood of pregnant women, and they're extremely low in cervicovaginal secretions when the amnion is intact. Premature rupture is associated with preterm birth, as well as serious complications such as chorioamnionitis and fetal sepsis, because this is a barrier. That amniotic membrane is a barrier between the outside and the safe place. And so if it breaks, if leaking amniotic fluid, then bacteria can theoretically get in there and cause infectious processes. False positives can lead to costly and unnecessary medical interventions, so it's very important to determine if this has occurred. The collection of vaginal secretions for premature rupture of the membranes does not require a speculum, and sampling should be done before performing a digital exam. A sterile polyester sample swab is inserted into the vagina and allowed to absorb secretions for 1 minute. Note that during the collection, you have to avoid those contaminants, as with any other type of collection, lubricants, disinfectants, soaps, or lotions. The swab is withdrawn and immediately placed into a vial that contains a solvent. It is rotated for 1 minute to elute the vaginal secretions. The swab is removed and the vial is transported to the laboratory for testing. Rapid ELISA test is performed. This is not mentioned in your textbook, but I thought I would throw it out there, and it's called the Fern test. And this is a test used to differentiate amniotic fluid from maternal urine. The cervical mucus is smeared on a glass slide and allowed to dry, and then it's immediately examined under the microscope, and the doctor will look for a fern-like pattern. This is usually done by the doctor. Many times I was interrupted doing my work by a physician wanting to borrow my microscope, which was fine, because this takes a few seconds. You look at it, is ferning present or not? And this is performed to see if there has been premature leakage of amniotic fluid, and again, it will create a fern pattern due to the protein present if this is amniotic fluid, as well as come to class with any questions.